So I'll be talking about phakic materials and patient selection. And as we all know that phakic have been here for long, and most of us have been doing them for some time. I'll be concentrating on a little bit on the materials, some of the studies which I could lay my hands upon, and the criteria for selecting patients, who are the patients to be done, where are the troubleshooting points, and which are the patients not to be touched. So I'll be starting with more than 2,200 cases done, helpful tips. I have no financial relationship whatsoever with any of the products I'll be talking about. Yes, I am a consultant, but I just do that for a hobby on design and materials. I do it as a hobby. I do that for most of the companies, but I have no financial relationship, no honorarium, nothing, and let this be there forever. Okay, so there are various options of phakic lenses. We have a very large experience with IPCL and ICL, though I have used the APA lens and the RIL and also the biotech lens. But I would mainly be concentrating on two market leaders, as ICL, as we know, is a market leader, and IPCL is number 2 in the world. And I think it's all made in India, desi stuff, and the way it's going, and I feel it's probably going to be the number 1 lens in the coming few years. So focusing on the materials, mainly the materials are the same. The only difference probably would be, I've highlighted that the water content of the ICL is slightly higher, and the ICL also has a collagen, which is porcine, which is 0.2%. The IPCL has got something extra, third butyl methacrylate, approximately, which actually imparts the monomer strength. That is the reason which in the V2 model, that even with a bad watt, you will not get a watt lesser than 450 or so, because the rigidity of the material doesn't let the IPCL collapse, of course, unless you have a high lens size. Now, I will concentrate on the benefits of using this high rigid material, what they do to the structure and the surface of the lens. This is a study done by Dr. Thiers, and he's a friend. He's in Madrid, so he shared this study. I also borrowed it from people in the company. He did an atomic force microscopic analysis of the surface of majorly ICL and IPCL, and he studied in his lab, and he used an atomic force microscopy, and the results were quite startling. The results was that he took 4 IOLs, and he, of -12 each of IPCL and ICL. IPCL was version 2 and ICL was version 5. This is the force atomic study of the surface, and as to our surprise, this is the structure of the surface of the IPCL, and this is the structure of the ICL. And what I guess is that the little bit of surface rigidity which the third butyl material gives to this lens actually gives it a very, very smooth surface and a very good refractive index. So the conclusions of this study were that IPCL, according to him, was statistically far more smoother in anterior surface than the ICL. Another corollary which he drove from this study was that smoother the surface, lesser the pigment dispersion, lesser the light scatter, and better optical design. So after having discussed the materials and surface, now I'll be coming on what are the contraindications of phakic IOL. Contraindications, as any kind of cataract, if you think, and of course, unless it's a developmental cataract and it's not progressing, could be a contraindication. Corneal dystrophies, bad endothelial cell counts, anterior chamber depth less than 2.8 millimeters. But yes, you lesser anterior chamber depth in special cases, but for beginners, I would not recommend that. History of uveitis, posterior sphenicae, angle pathologies. I've had 2 patients where I did a IPCL and the lens was vaulting again and again. And I realized that we did a UBM, and I realized that there were iris cysts in these patients. We had to explant the lens. So after that, I made UBM study a mandatory protocol in the preoperative. History of retinal detachment or shallow RDs, of course, for me, it's a contraindication. Keratoconus with very, very steep cornea, it is mandatory to measure the angles, and you need to have a good peripheral angle before you proceed with these cases. For your patient selection, what I would recommend would be that, if you have a very high power, of course, IPCL is the choice. Even if you have a very large pupil size and large corneal diameter, IPCL would be the choice. Because I have actually put IPCLs up to 8.5 millimeter and 14.25 millimeter of optic diameter, of total diameter. Cylinders up to 11.5 diopters of astigmatic corrected with the IPCL. Large optic sizes, large sizes, So then my choice of lens is that. Another advantage with IPCL is you have a huge inventory of sizes available. So you can actually tailor fit your sizes. 11.5 to 14 is the standard pipe. Optic size can be personalized. We have a smart lens. So what happens is, in case you have a patient with astigmatism, I prefer going in for an IPCL because they have smart lenses. You don't need to dial them. You just put them 0-180 and they're perfect. Cylindrical power options are available up to 11 diopters. Now this is a post-operative image. All you need to do in an IPCL is 0-180. In ICL, you need to study a chart which is given along with the lens, and you need to dial the lens according to the patient. Now we have a experience with nearly 2,345 cases, and this is a brief summary of all. The incidence of cataract is 9 cataracts I've had. 2 patients were the ones who had retina detachment surgery. So post retina detachment surgery, 2 eyes had a silicone oil induced cataract. Other patients was a case of bad measurement and bad fit in my initial cases of study. So this is where I come to the major punchline of the slide. Refraction is the bottom line. You should have a very, very accurate refraction. I recommend a cycloplegic refraction for all my patients, because a lot of times these patients may be sometimes wearing overcorrection of their glasses. They could be accommodating, and you can land up getting a wrong calculation. Second thing is, in case you have an astigmatism, especially more than 2 diopters, also measure vertical white to white. If the pupil size preoperatively, scotopic is large, please order a large lens and mention a large in the file. Another thing to notice is that non-dilated pupil, if it's large, that's something to watch out for. And another interesting point is, if you're trying to dilate the patient and the patient is not dilating well, maybe let's say around beyond 8 to 8.5, you should be careful, because in case, especially if you have a large cornea, it'll be difficult to put a large size IPCL, let's say 14 millimeter lens through an 8.5 millimeter of a pupil, which is maximum dilatation. So watch out. Keratoconus patient, you should watch out. As I said, these patients will give you a false deep anterior chamber depth. You need to calibrate your anterior chamber depth and also measure the angles on an OCT. High risk group, since these patients are high risk group, do a meticulous posterior segment evaluation, rule out posterior segment pathologies before you take these patients up. Another important thing is that these patients could be prone to be steroid responders, this category of eye myopes. So please do a long follow-up with these patients. Also take history of glaucoma in the past, or any time some steroids have induced the steroid-induced glaucoma. Intraocular pressure records, if available, is perfect. Disc evaluation, OCT and fundus imaging. Gonioscopy and angle measurement, of course, is fantastic. Specular microscopy, if possible, in Europe. So what are the issues we've encountered? Very large pupils. I've used up to 8.5 millimeters, as I said. Very large corneas, you need to actually go in for a larger lens. So make sure that your pupil dilates well. Secondary piggyback procedure, I've used it for patients whom I've operated 15, 20 years ago, and they are posterior sanique, so I needed to break the sanique. So I needed a thinner lens rather than a normal piggyback lens. So learning points here were, always focus on your white to white. This is the break point. Your white to white is a break point. You should be very, very careful with the measurements. Watch out for IOP rise within the first few hours, especially it could be due to retained viscoelastic. But if you're seeing an intraocular pressure rise after a few days, this could be a steroid responder. Initially, if you're getting a Walt low, please remember, if you use the pilocarpine or a carbachol, the Walt will go down by 100 to 150 microns, which will improve over 2 to 3 days. And if you've left some viscoelastic behind, the Walt may be up by 250 microns, which will settle down by 4 to 5 days. The best way to differentiate is, if you have a higher Walt, do an OCT, ASOCT, and you might be able to see some viscoelastic there. Don't be confused. If you see some whitish material behind the phakic lens in the initial few days, this could be retained viscoelastic. So let's see. If you have a large pupil, please note, contact lens trial is recommended for patients, especially who have intermittent squint. Mention a squint in your file if it is there. I've had 2 patients who had intermittent squint, but we forgot to mention in the file. And after that, they ate my head up. After the surgery, they said that I've induced the squint. Another thing is, if the patient has an amblyopia preoperatively, please mention it in the file and tell these patients. Most of these myopic patients may be 6'9", 6'12", best corrected in one eye. And once you do the surgery, they expect to be 6'6". So please warn them, mention them in the file. Pupilometry, dynamic pupilometry, I'll be very fast. Sonu, I'll just spend 1 minute extra here. Planning for phakic oil, this is the most important part. Sizing, you can use a vernier caliper. I would not recommend it. I only use it as a confirmatory mechanism. I use a cirrus to do that. Which if you use a vernier caliper, use the mid-limbal line. You can use this digital caliper marker. We have also standardized autorefractokeratometers in most of my clinics, and the nomograms have been set. In some of my clinics, we are just using an autorefractokeratometer to give a very, very accurate calculation of this particular thing. Now, one final slide is, if your interior chamber depth is more than 2.8 millimeters, are you safe? Well, I would say probably not. Look for angle anomalies. Look for a resting large pupil size. In case you have a resting large pupil size, you will be ordering a larger lens. Then a simple 2.8 millimeter is not good enough. You probably need more than 3.1. So my nomogram is, if I am planning a larger size lens, I look for a ACD more than 3.1. Otherwise, I plan for a little bit smaller optic size. Resting pupils, non-dilating or small pupils, watch out. If you have a small dilating pupil, it's no use. Even a 2.8 millimeter is not enough. Flat iris for configuration or a plateau iris is a relative contraindication. Plan a little lower vault if possible, but you can only plan a lower vault if you have a lower lens size. Irises, keratoconus, and posterior sonic. These are the things to watch out for. And this is what a lens size is, an angle to angle line drawn from each side. If you take the distance from this to the amount of anterior capsule distance, this is the lens size. I think I'll stop Dr. Sonu here. Thank you.